Hi, and welcome to Technology Evangelist Podcast. I'm Dr. John Flucke, and I'm grateful for sponsorship of the podcast by Medidenta Digital. And today I have a really good friend of mine who's an oral and maxillofacial radiologist. He's going to talk to us about what he does and the ways that things in 3D can change what you do. I'd like to welcome my really good friend, Dr. Dale Miles.
Good morning, John. How you doing?
I'm doing well. Before we get going,
Yeah.
I want to tell a quick story to everybody just so they have a little background on this. One of my first lectures that I ever did was at the American Dental Association in San Francisco at their Technology Day, and they paired me up with a couple other people, and we took turns. And one of the people was Dale. So I've known Dale since 1998 or 1997. And then the other interesting bit about this is, as I said, Dale's an oral maxillofacial radiologist. And a few years after we met, early 2000s, their association, the American Association of Oral and Maxillofacial Radiologists, had their national meeting in my hometown of Kansas City. And Dale reached out to me. He said, "You got to come down and see this." And I thought, okay, I mean, I'm sure I'll learn something, but I'm not really sure, what I'm going to learn that's going to apply to me. And they showed this. I went in for a panel discussion that Dale was part of, and they were talking about this ridiculously expensive but incredibly cool thing called cone beam computed tomography. And I sat in that room with my jaw on the floor. And the one thing I learned when I walked out of that room was thank God there's radiologists, because it's like, how can anybody ever understand all of that information? And yet, jump forward to now, and lots of us have got cone beam in our office. And for those of you that come across something that you don't know or you don't recognize in a scan, there's people like Dale that will actually read your scans for you and provide a complete radiographic report on all the findings. So something to know there. So Dale, tell me, I always kind of start off with tell me your origin story. And I sort of told you my origin story with you, but tell me your origin story, how you ended up where you are today.
Oh, wow. It's quite an odyssey, actually. I practice dentistry. I'm a Canadian graduate from the University of Western Ontario in London, way back 54 years ago, by the way.
Wow.
I practiced as an associate, and then I ran my own practice for about 5 years, and I got bored, John. It was very technical. I wasn't using my head. The materials weren't like they are today. The toys weren't nearly as fun. And so I went to graduate school in San Antonio, sold my house, my car, my van, my practice, moved to my 3 and 5 year old and wife to Texas and did graduate work. When I did that, radiology was not a specialty in the US. So I went back to Canada to teach at Dalhousie University in Nova Scotia. And from there, the Odyssey goes University of Connecticut as a visiting professor, where I actually reintroduced panoramic to those guys because they were very anti-panoramic, and now it's
Wow.
ubiquitous.
Yeah.
Then I was hired as the graduate program director at Indiana University for a program in oral medicine and radiology. So I did that for about 11 years. Then to Kentucky, University of Kentucky, as chair of half the school for about 4 years. It was an interesting place to be because they'd gone from 14 departments to two. So, so
Whoa.
that was, yeah, there was a lot of disgruntled folks there at the time, but it was still a wonderful place to be. They recruited me from University of Kentucky to be the first dean of associate affairs or clinical affairs at the Arizona School of Dentistry and Oral Health, which is AT Still University, the first dental school. Now there's two. And in 2005, I decided I'm going to do private practice again and basically do oral maxillofacial radiology full time. So I left academia. I'm a recovering academic. Okay, so I, but I've enjoyed every minute. I've read 40,000 scans. I've done lots of research papers and writings. I've lectured everywhere, really worldwide. I counted it up the other day. I think I've been to 63 countries. So
That's
um,
incredible.
it was incredible. But now I just work at home in my study, reading cases, and I'm still doing research. I'm doing research on things that I find in the cone beam scans.
So you introduced me to something not too long ago um, that I found fascinating, and I think it's really going to change the world of dentistry. A lot of us, probably everybody practicing now, is familiar that there's artificial intelligence that you can use to aid your radiographic analysis and diagnosis. But Dale called me, I think it was about August of 24, and said, "Hey, I want to tell you about this company, Velmeni, and they're using AI and cone beam." And so we set up a Zoom meeting, and he brought in some of the folks from Velmeni, and Dale and I were there, and I sat there and I was just like, holy cow. So give us a little bit of that, Dale. Where is AI taking us in this whole 3D thing now?
Yeah. Of course, thank you, John. Of course, the first part of AI was always with the 2D images that the dentists take, because that's a fairly simple, straightforward task to do. Look for carious lesions, look for bone levels, look for periopathology. Of course, it graduated to panoramic, and some companies even then said, hey, we can take CBCT and reconstruct a panoramic and perform these same operations. So we're really moving into a lot of different areas of AI, not only the diagnostic side, but also for planning implants, planning surgical guides, and it all evolves around digital technology, the cone beam scan, and then basically STL files that are then sent to a lab. And so this technology is here to stay. The AI portion is going to be interesting because you can actually ask with the right amount of data, which is as much as you can get. Okay. Um, the AI programs are data hogs. So the more data they get, the tighter they get. And it's going to be able to basically look at any type of imaging modality and give you either a segmentation picture or a colored picture of what it is that you should be seeing in your radiographic information of whatever flavor that is. The dentist still owns the responsibility and still has the final decision making, but AI will basically give you a probability of, that yes, this is a carious lesion, or yes, this is a airway problem, or whatever. So the impact is huge. And right now, no one's doing full 3D AI from cone beam scans. Velmini is in FDA approval for all of that, and I think they will be the first ones to actually get there. And that's been a key part of my sort of function with them, is to help them direct. But I'm not the only radiologist. They have at least 20 or 25 radiologists worldwide that are actually feeding into this particular company and the program software that they're creating. I do have a dog in the hunt. I showed them a software that I'd created as a standalone product with a company called Cybermen years ago, and the development was good, but the development wasn't going rapidly enough. And so I sought another company and found Velmini, and they have not only made a standalone product called EasyRiter, but put it in their 3D software. And if you got a minute, I'd like to explain what it is, because I think it's going to impact you, and everybody that's using CBCT. So,
No, in fact, that was where I was going next. So tell us about EasyRiter, please.
okay. Well, EasyRiter it's basically it's a way to get to a structured dental report that basically is anatomically based. As a radiologist, I look at the same things every day. I look at the paranasal sinus, nasal cavity, airway, temporomandibular joint, cervical spine, and other osseous structures, dental, and then medical things that are in the scan, which there's quite a few of that people don't realize. And so I looked at that and I said, I dictate the same things many, many times a day. So why don't we codify these statements so that a dentist looking at a volume, capturing a screenshot or whatever, or while they're looking at the volume, can just click on a statement and populate into a report. Um, it's very simple. It's very easy. Currently, it only has a slight bit of AI in it because we're building out some of the things that are important. And dentist isn't looking for, but really needs to know is in the scan to make the proper referral to the patient. So I built in a lot of decision support too. For instance, if I was demonstrating, I would show you a simple one, like cerumen. What the heck's cerumen? Cerumen is earwax. What dentist is looking for earwax? Well,
Right.
nobody is, okay? But I see it all the time. It is a primary cause of conductive hearing loss. And basically, when you see it in a scan, it's important for the dentist because we all look at the temporomandibular joint. Patients come in with joint pain. The cerumen buildup is one of the primary referral areas for joint pain. And who knows that? I mean, as a dentist, we weren't taught that. I learned
Right.
that along the way in oral medicine and radiology. So that's an easy thing to identify. It's an easy thing to make a recommendation for. And we put that all in the report. You can add the image to support it. It has citations, like if you go cerumen, what's that? And you click on it, it'll tell you what it is. It'll show you an example from the cone beam, and then you can embed your own image that supports what you think you just saw. So right now the dentist still drives the car, the AI car. But we're getting to the point. I brought 7 or 8 items to Valmini that I said these things have to be seen by dentists. Very few of them are. That's why we find them and tell the dentist about them so that the patient gets appropriate treatment. Well, we're building a lot of that into the AI, and they are so rapid to program that once I give them the data, once we add more data from other radiologists, we're going to make a very robust package. And it's very
Well,
simple to use.
the thing that I think is kind of interesting is that I was an early adopter on cone beam,
Yeah.
and because of that, I got a chance to, kind of lecture on the general dentist's perspective on it. And I had, just tons of people would either, in the audience ask or come up to me afterwards. And, they would be like, okay, I know I can take it, but I don't know what I'm seeing. And I'm kind of afraid of this because I'm going to be legally liable if I didn't find something. And I would always tell people, well, send it to Dale, or do a Google search on oral maxillofacial radiologists that read scans, and you'll find people that offer those services. But the nice thing I think about this whole package of Velmini and EasyRiter is that you don't have that time it takes to package up the DICOM, send it to a radiologist, have the radiologist read it, although most of them are pretty quick about doing it. Um, but being able to take a scan on a patient and either while the patient's still there, tell them this is what we found, or even to call them the next day and say, we've analyzed, this 3D x-ray we took of you, and here are some things that we found. I think those kinds of situations, being able to kind of go outside, I don't want to say outside the scope of dentistry, but the general public has a certain perception of what we do. And I don't think a lot of people have a great appreciation for how much knowledge, dentists have, and
We
being
really
able to,
have. Yeah.
yeah, and being able to tell them, okay, we saw this we've identified it as a potential problem, or you might want to see an ENT, or you might want to go to general physician and at least tell them what we saw. We can send this info to them. I think it's a tremendous practice builder. It's a tremendous trust builder with patients to know that we're really. I always say that if there was any logic to our whole medical system today, dentists would be physicians with a specialty from about the shoulders up. But because
Yeah.
of that division, we have dentists, and then of course we have physicians, and people just don't appreciate how much we know, and oftentimes how much we see that, you know, people don't realize.
Yeah, I think you're correct. I think we'd be like an ophthalmologist because they have specialized area, they have specialized tools that they use. We've all been for an eye exam, you know what I'm talking about. Well,
Hmm.
dentists should have been the same way. The thing is, what I try to do, and see, people say, well, does every scan have to be sent to a radiologist? I say no, and that's exactly why I tried to build a software that was easy to use. If a dentist goes through it and there's still something they don't know, I mean, they can describe it, put it in the report, whatever. But I call them an I don't know ma. Okay, they see
Hmm.
something they don't
Yeah.
know, they go, it's an I don't know ma. Well, those are the ones you would send to the radiologist because currently the estimate is that only 10 to 13% of all cone beams exams taken are actually sent or read by an oral maxillofacial radio. We're not going to be able to keep up. I don't care how many people we graduate in the next 10 years. We don't have the numbers, just like medicine. Medicine sends a lot of their scan data for an initial read to expat radiologists, ones that have been trained here, then went back to their country, they do the first read, it comes back. I don't think we'll ever get to that point, but we have enough data to get to that point. So
Yeah.
what I did is I said, okay, John's sitting in his office. He wants to do a quick review of his case before he drags his little lines to the implant site and starts to plan that. He has to review these slice data. Well, as you're going through and you see something, it's easy to see it, click on a report, populate it, and put the image in right at that time. So I built this for, I hate to call you this, John, but you're part of the low hanging fruit. Okay.
No,
You're
that's
part of the
okay. I
people,
get it.
you're part of the folks that I think really need this. And it's because I'm a dentist first, then a radiologist, then an educator. I anticipated what are my colleagues going to need? And you were very acute when you said my people come up to me and say, well, I don't want the risk and liability. When I start off lecturing, I show Steve Martin and Bill, uh, oh God, the guy Bill Murray. They come out on stage, and Steve Martin's going, "What the hell is that?" And then the other guy, you know, they come in and they both go through it. And so I use it. I say, "This is two dentists looking at a scan. These images are great. What am I looking at?" They do not
Yeah,
know.
exactly.
So we also have to educate people. And I do that, all my radiology colleagues do. There's a ton of us out there that are given programs and courses now all the time. But I've been doing it for 14 years at the University of Toronto because those poor Canadian dentists in Ontario can't even buy a machine until they've had 30 hours of university-based CE. And
30
so
hours,
30,
30.
yes.
That's what you said.
Yeah,
Wow. Okay.
you got it. And so I go there and I give them a 30-hour, I do a 2.5 day program, which for the hands-on, it's double,
Hmm.
hours and whatever. So we get to the 30 hours and it takes me 2.5 days to really get them up to speed. But you know what we do on the last half day, and we've done for the last, I would say, 5 or 6 years? We have them go through an unknown case with EasyRiter so that they can populate it. Okay. And they love it. They go, wow, this is great. And it's fun to watch them because we put them in pairs. And the pairs, when they're doing it, they're scratching it. What is that? I mean,
Yep.
they really even have to think about what was I trained to identify in dental school? Is that what I'm looking at here? So I've been doing that forever, and I would continue to do that in a spot if I could find one. So
Well, and the I don't know more, which I love. Um, I tell people I look upon it kind of like I do a light assisted oral cancer screening on
right,
every exam that I do. And I don't know if something, under the wavelength of light, anything that isn't normal shows up black. So
yep,
I don't know if it's, buildup of tissue. I don't know if it's, something malignant. But what I do know is that if I see something like that, that's when I refer. That's when I call in the experts. So I don't need to know it's a squamous cell carcinoma. All I need to know is I don't know what that is, but it doesn't belong there. And then,
yep,
I bring in the cavalry. And I think I think having something like EasyRiter is sort of like just being a scout for the cavalry. I mean, you've got the backup with you every step of the way. And now it can help you identify those things. And if you're still not comfortable, then go ahead and send it to a radiologist, or go ahead and send them out to a specialist. Um, but looking and knowledge is powerful. Having that knowledge either a few minutes after you take the scan or even a few hours after you take the scan, that's powerful stuff.
Yeah, it's huge. And I'm going to add one more thing because, dentists, we all, as a dentist and as a radiologist, we got quite excited about finding the sclerotic plaques, on
Mm-hmm.
panoramics
Yeah.
that suggest the patient is at high risk for hypertension or stroke. But there's more calcifications than that, and we've built that into EasyRite. This is going to be the game changer. Atherosclerotic plaque is in the intimal layer of your artery. It's a blockage, okay? By the time it calcifies, it's pretty stable. It's probably not going anywhere. So yeah, the risk is there, but it's minimal. The person that dies of a plaque is the fibrous plaque, the stuff that's not very, it adheres to the wall, the intimal layer. It has some schmutz in it, and it throws a piece and it goes to your heart, your lung, your kidney, and you stroke out or have an embolism. But what's really neat, I've looked at this now for 15 years, and I have well over 700 cases of a different type of calcification that occurs in the scans that I see every week. And I mean that every week. And it's called medial arterial calcification. It's in the next layer. And we have vascular smooth muscle cells that are laid down in concentric circles in our muscular layer in the artery to expand when we need more blood and to contract when we don't. Well, guess what? When the inflammatory products from your periodontal disease or other problems get to the intimal layer, they change the permeability of that intimal layer. Stuff goes through into the medial layer, and the vascular smooth muscle cells lay down bone. They lay down bone in these patterns, concentric circles, part of circles. If you turn and look at another sort of plane of section, it might look like a parallel linear lines.
Which is the joy of having it in 3D, obviously.
Exactly. And so we've got that built into EasyRiter already, and it's going to come out as a segmentation, and it's going to be a game changer because now what does it relate to? A person with undiagnosed or uncontrolled type 2 diabetes. So dentists are going to be able on their scans to have a tool that says, consider this, just like you said. It'll pop up, it'll give them a little warning, and it'll already be in the report because they will have seen the patterns. I have lots of that, and I don't want to take up more time, but I got lots of that on my YouTube channel, and I'm publishing that all the time, and I'm lecturing on it. I lectured in several different places over the last 2 years, including, are you ready for this?
Huh?
I lectured in South Korea during COVID.
Oh my
Okay.
gosh. How did
I
you
got
pull
an
that
ex
off? Oh my gosh.
I got an exemption for business and I had to be quarantined, but it was only 24 hours in a local South Korean hotel. They tested us before we left. I had to have all the documentation. Tested us in the hotel, gave us a bag lunch, locked us in the room, and then 24 hours later, they let me out and I could go on my way. So I was the only non-Asian at this international radiology conference to
Wow.
present mine live. So it was wonderful. And I want to thank Cybermen because they were the ones that helped support getting me there because it was their software I'm using to do this.
That's
Yeah.
incredible story.
So 2021, I got to go to South Korea wearing a mask the entire time.
You
And I
know,
was drinking.
kind of a little funny sidelight about this is in January of 2021, I was at a meeting, and I won't talk about it was a company that invited myself and a few other doctors out to meet with them. And we got there, and one of the people, we were in a hotel little conference room, and one of the gentlemen there was Chinese, and he had quite a bad cold. And he said, "Yeah," he goes, I was just home, and I picked up a bug while I was home." And he's coughing and he's sneezing, and nobody's thinking anything. But we're like, "Oh, God bless you. Gosh, we hope you feel better." And I got home thankfully I didn't get sick, but about, a month and a half later, all of this is all over the news. And I thought to myself, oh my gosh, if I'd have been in that room today, I,
Yeah.
I, I would have been petrified, to go through that. And of course, nobody was testing, so we don't know what this
Yeah.
gentleman had, but it's just kind of funny how the world how it changed in an instant
Yeah, it's
to,
huge.
you
The
know,
change was amazing. Amazing.
yeah.
Yeah.
So I know that people ask you all the time about standard of care. And I know that standard of care is kind of a fluid thing. It depends on geography and a lot of things. There's no legal definition that says if you're doing X, this is the standard of care. So with the proliferation of cone beam and doing virtual implant planning and then using surgical guides, where do you think we are in the legality of all that? I mean, like I said, I know it's not malpractice to place an implant without a cone beam, but what's your opinion as we kind of move, I think, more and more towards that realm?
I think we've already got there, John, and I was
Okay.
in your same mindset where I said, the standard of care hasn't suggested we need cone beam for any of these tasks. Unfortunately, I do enough expert witness that over the last, I would say, 5 to 6 years, the lawyers have convinced me that for implant placement, it is, even single implants. For third molar extraction, it is. Okay, so it's evolving, but it's evolving very rapidly. And I've been in the courtroom, and I've basically been an expert witness and
Hmm.
watched the lawyers convince juries that yes, this was a problem because this was not taken. What I haven't seen, which is makes me feel good, is that I haven't been in a court of law or an expert witness situation where someone missed a diagnosis and got sued. And that's the thing that everybody worries about.
Right.
To me, it's the next step. And I hate to harken back to the EasyRiter or the templated report, but the better your documentation is, just like anything else we do in dentistry, the more protection you have. So I think it is. I think it's the standard of care for multiple tasks that we do. I think the dentists have to continue to educate themselves. The material is out there. I mean, look at Chat GPT. You can ask it all kinds
Hmm.
of questions and get definitive answers. I mean, part of the reason I know so much about the calcification difference between atherosclerotic plaque and medial arterial is because I asked the questions, and I've had Chat GPT come back and say to me, "That's an excellent question." Okay, and it's like, "Oh wow, okay, I guess I'm on to something." Okay, so and I've got those. I've printed them all out, put them in a little binder, so that I can follow that. But as a final point, when you take the scan, you're responsible for everything in it. Whether you look at it or not, or send it out to have someone read, you need that layer. You need to have looked. And I'll give you an example. Um, we always talk about, uh, the what's the legal definition? Consent. Okay,
Yes.
informed consent, and everybody signs it. And everybody says, yeah, but there's informed refusal too, and the two are tightly tied together. But just as the patient has a right to consent, they have a right to refuse. But that doesn't mean you get them to sign a document that they say, I refuse to have somebody look at the data, because they're not skilled in the art and science of dentistry
Yep.
to do that.
Yep.
So that's a thing that's in dentist's head that, oh, hey, it's medical. I don't need to know about it. No, you're responsible for everything in the scan. And if you don't want to look at it, then you'll have to have somebody that does. And just to finalize that, I tell dentists, look, if you're only doing 1 or 2 scans a week and then you do your implant case the following week, educate yourself. Get yourself to a level of comfort where you like looking at the scan. Find a product that helps you do that. Okay. But if you're doing 6, 8, 9 scans a week, in a surgeon's office, or you've got a big multi-practice, then you need to think about sending those out and setting up a formal mechanism, because you don't have the time. Dentists don't make their money looking at scans. They make their money chairside, doing the stuff that patients expect them. And so, and we'll never keep up. Like I said, we'll never keep up. So the dentist still has to, if you're only doing a few scans, I think you have to educate yourself. If you're in a busy practice and doing multiple scans, yeah, they probably should be sent out. Just my opinion.
Yeah. Well, and I will say on the whole litigation thing that I do some expert witness as well.
Yeah.
And the documentation, just in general, whether it's, radiographic or not, the documentation is so important because an attorney can make you look incompetent in a lot of different ways, even if you're not. And the more it's like treating patients, the more information you have, the better it is. And it's that way with your chart notes. I saw a situation where someone got involved in a interaction with a patient that went south, and the chart note said root canal number 30. And that was the entire note for that procedure. And even if this person does the best endo on the planet, a good attorney is going to take that note and make you look like you don't know. And, and that's unfortunate. So documentation is hugely important. One of the other things that I wanted to bring up is about guided surgeries, because Dale, I will tell folks, Dale has shown me more implants gone wrong, I think, than maybe anybody else that I know, in all seriousness. And I remember, I think the first time you were really showing me some into the inferior alveolar nerve and some other things, 3D printing was just kind of starting in dentistry, and surgical guides were starting to really, become something that you could do. And I will say I don't place implants. There's a dentist in the practice that does them really well. But when I saw what you showed me, I remember thinking to myself, I don't care how good you are. Why wouldn't you use a guide for the minimal expense of it, and the assurance that, with a guide, you almost have to try and do it incorrectly. So what's your feeling on that, Dave? I've told you mine.
Yeah, no, I think you're absolutely right. I think that especially in the learning curve end of it, dentistry and implant, and that's why people go to extended courses, because they want to know how to do it properly. I think even in the 1Z and 2Z cases, if you start out with a surgical guide, it's so simple to do, it's so accurate. You minimize your risk, you minimize your liability. I think it will. And here we go. I think it will become the standard of care. The number of implants that I've seen in premolar regions, the anterior region, where someone said, "Oh, I think I can split the thickness here and
Yeah.
just at the angle." And then where do I see them? I see them out facially, through the buccal facial cortical plate. The lecture that you might be referring to, I don't know if you've ever seen me do it, but I call it the Rocky Horror Implant Show.
Oh, no, I haven't seen that one, but honestly, next time you do it, let me know, because I would love to
No,
see that.
I show all of the horrible examples, then I show ways that you can avoid it, and then we get into some of the cases. Now, like you, I don't place implants. I can plan them in any software you give me. Okay. I don't make surgical guides, but I know enough as a general dentist to know if I were still practicing and I were doing implant cases, I would not do them without a surgical guide. So I think you're spot on there, John.
Well, and the amazing thing to me, honestly, is when I started to look at surgical guides and how they work, I got a whole new level of respect for the people that had been doing implants freehand for, for
Yeah.
years and years. When you think about trying to go in and control your hand, mesial distal, buccal lingual, and internal. I mean, the skill set that's involved in that is just, I don't know, mind blowing. And, surgeons can sit down and bang, 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 put out like a whole arch in, a decently short amount of time. I was just like, I don't even know how those people do that. And I do think we're going to get to the point soon where older dentists will say, remember when we used to just freehand those, and they'll laugh. It'll be like when we talk now about the dark room. Remember how we used to have to, run into the dark room and take 5 minutes to have a PA out in endo, and the endo was a half hour longer because we had to wait for the film to develop for every step.
Yeah.
Um,
And you couldn't open the door because you'd let all the dark out.
that's
Mhm.
one of
John,
the happiest. Oh, go ahead.
one of the things I want to circle back to, I hate that expression, by the way, but this is a good works here.
Yeah,
One of the things that I've been developing, and I have a lot of information on, is implant failure secondary to the lack of knowledge of the patient's diabetic status. So I want to come
beautiful.
back full circle here, because
Yeah.
what I found is when we send, like, just since December, I've just with one client, I have seen 212, no, 312 cases, okay, of just cases she sends me, and she's does obstructive sleep apnea.
Okay.
Well, in those 312 cases, 38 of them had the calcification patterns that suggest diabetes. Okay, so
Wow.
that was about 10 to 12% of her, and that's one dentist. Okay, now the recommendation that we make, and this dentist always sends them out for that, is basically patients should be referred to the primary care provider for evaluation of hypertension and stroke risk, as well as undiagnosed or uncontrolled type 2 diabetes mellitus. Evaluation should include serologic levels of hemoglobin A1C. The number of times she sent that out, and they go, oh, and half the time their family history has diabetes or hypertension or some kidney issue. So we're picking this up on literally on a weekly basis. Okay, with one patient, or one client, and I'm about to publish a huge study comparing atherosclerosis, just the ones we see on PANS, to these other calcifications. And when dentists start doing this and recognizing it, we are going to get more people into appropriate care that are, were pre-diabetic or whatever, that, and then improve the quality of their life. So this is going to be huge impact, I think, on the general dental, sort of practice, because they're taking cone beams and it's there. We just got to get them to recognize it. So that's what
Well, and
that's
it's a prevention, and heading
the
things
whole
off
health.
before they get bad. Yeah,
Yeah,
absolutely.
yeah.
You know,
We are looking after there's a patient on the end of that tooth, remember?
yeah, yeah. Well, it's like with the big measles outbreak that we've had
Yeah,
this year. I mean,
yeah.
the oral,
Terrible.
if they get oral lesions, those show up about a week earlier than the
Yeah,
other symptoms. And people don't realize that when you're a dentist, you can actually find things that are either undetectable, or by anyone else that's looking at the rest of the body, or that in a case of like measles, which is so infectious, you've got to see your primary care doctor right now and have them evaluate you, because that stuff spreads. If you're not
yeah.
immunized, the infection rate is 90%. And the last thing you want to do is be responsible for, a huge outbreak in your area. So anyway, there's just a lot of things that we can do and see, um, that once again, I don't think patients realize. And, it's like taking blood pressure at every appointment.
Yeah.
I don't know how many people that we've referred,
Hypertension.
yeah, for hypertension, and not to brag or make myself look important, but I've had the great feeling that comes with people coming in and saying, like, I think you saved my life,
Thank
or I
you.
think you
Yeah,
saved
yeah,
my spouse's life, kind of a thing. And that's incredibly rewarding to
yeah.
do that. And I didn't always take blood pressure when I first started. Um, and I wish I would have. I got guilted into it by a buddy of mine who, well, Ken Reed, right?
Yeah, sure.
Yeah,
Yeah,
Ken Reed was the one that,
got you going.
yep, yep.
Well,
He started
I'll
talking
tell you,
about numbers, and he was like, and why wouldn't you? And I was like, that's a great question. I start today.
I have an adjunct appointment at the new school in El Paso. Okay, and I have a good friend, Bob Danforth. He and I are doing research on the cone beam and the diabetes. But get this, every patient at the entry level at input, every patient, of course, has a blood pressure, evaluation at the beginning and at the end of each appointment. Every patient gets a hemoglobin A1C because in that region of the country, as is where I live, basically a lot of Hispanic, a lot of Black, a lot of populations that are at a higher risk for
Yep.
type 2 diabetes, and we're picking it up like crazy. And now we're validating it on the cone beam scans. So despite my youthful appearance, I'm in my I'm in the winter of my life right now, and I'm still doing research trying to help my general dental colleagues, understand the patient and the body that's attached to it. So.
I will also say that when I met Dale back in the later 90s, we were both completely white-headed even then. So
And we earned every one of them.
we did, absolutely. Well, Dale, as we get to the end of our time, anything that we haven't covered or anything really like cool and cutting edge that you can think of that you want to tell people about?
I don't think so, John. I think that we've covered most of the things that I was interested in talking to you about. I do want to commend you on your technology evangelist label because
Thank you.
you have been way out there you're always on the cutting edge. I'd like to think on radiology I'm on the bleeding edge,
Right. I would
but
agree.
I think that we do have an insight into what our fellow dentists should be looking for and should be adopting. And technology evangelist, perfect label for you, buddy.
Well, thank you. I appreciate that. I like to tell people, let me make the mistakes and then I'll tell you about
Okay,
them so that you don't make them too, which is
there you go.
kind of my raison d'etre. Why don't you tell us? I know you mentioned EasyRiter, and I know that's a passion of yours, and Velmini. Why don't you tell us real quick how people can find out more information about those products?
Yeah, both of us have the extension on our websites, Velmini AI,
Okay.
Velmini, Velmeni. And by the way, do you know what that stands for?
Um, you know what?
It's the
Honestly, I did, but I don't. So remind
You've
me,
forgotten.
please. Yeah, I have forgotten.
Well,
You've told me, but I don't remember, and I'm
well,
sorry.
I asked the CEO, I said, what does Velmini stand for? She said it's the Icelandic word for robot.
Oh,
Isn't that
that's
cool?
cool. That is very cool. I
So
like
we
that.
have Yeah, we have EasyWriter in the Velmini AI, which will come out with their 3D product when it finally launches, the one that's in FDA approval.
Right.
But in their 2D product, and then I have a standalone, and they can just go to EasyWriter.ai. EasyWriter is spelt with a T, EASYRITER, because if you spell it any other way, you go to places you don't want to be. Okay,
Yeah, I
so
can completely believe that. So, okay,
there you
great.
go.
Well, I don't know why I didn't remember the Icelandic word for robot. That's like a trivial thing that should stick with me. It's in there now, I think. I don't think it's going
There you
anywhere.
go.
Well,
Well, it
Dale,
gets my
think,
my
go
John
ahead.
John
No,
my I know you're gonna wind up, but I you
yeah,
just triggered something.
sure. No, go
My
ahead.
father my father before he passed found out he did a lot of reading and he would say, he found out that we only use about 10% of our brain capacity.
Yep.
So his favorite expression has become mine. He would say to me, Dale, I've got brains I haven't even used yet.
I love it.
We all have.
We all do. It's a constant journey. It's a
Yep,
constant journey. Well, Dale, thank you so much for spending the time and spreading some of your knowledge. I really appreciate it. You're a
my
dear
pleasure.
friend, and I can't think of anybody that would have been able to cover what you covered as well as you did. So thank you, and thank
Right.
you for all the hard work you've put in over the years. I know academia isn't always an easy path, and but we've got to get trained, and
Yep.
so I appreciate it. Thank you very much.
You're welcome, John.
Uh,
Thank you.
Everybody, We're wrapping up for today. This is the Technology Evangelist Podcast, sponsored by Medidenta Digital. I'm Dr. John Flucke. Thanks for watching.